So we have our patient volunteer here who's going to help us explain where the symptoms of lumbar facet disease. So tell me about your pain.
So it's usually a little stiff and it hurts in the morning, but then throughout the day, as I'm being active, it's a little less, but at night, then it really gets unbearable.
No, that's actually typical for joints in general. As anyone who has knee arthritis will tell you, it gets stiff. Weather makes it stiff, and as they move around a little bit, it tends to be a little bit better. Lumbar facet disease is very similar. What else makes it worse? Any posture, any motion, anything like that?
So if I stand too long, it definitely hurts a lot. Sometimes if I reach backwards for something, I really feel it, and then it goes down the leg a little bit.
Excellent. Now, so we always want to know about where the pain is and where it travels to. Now, we have to make a little distinction between referred pain and radiating pain. I'll tell you the difference in a minute. When we talk about referred pain, it doesn't follow what we call anatomical dermatomes. I mean, we'll put that aside for now. But radicular pain or radiating pain is more of a function of a large nerve. So, for example, in this model, if we have a herniation that is, you can see this herniation pushing on this large nerve, the patient will say, wow, I feel it, it shoots down, it goes down to my foot. Facet disease often does not go past the knee or into the foot. Big nerves, yeah, that can go all the way down to the foot. Facet pain is often limited in the lumbar spine we're talking about, up to beyond the knee. And she was demonstrating how this pain is. Watch the motion again. So she bends backwards and towards that.
Oh, yeah, right
there. Yeah, there she is, bending backwards towards the left. So on this model, so this is how she'd be standing here, bending backwards and towards the left. If you notice, what's happening here? The joints are being squeezed, right? The joints are being squeezed and they're rubbing. Now, if it's an arthritic joint, the surfaces are red and irritated, and you start rubbing that joint or putting pressure on that joint, that hurts. Now, often I'm asked, well, how did I get this? Well, a lot of it is genetic, and a lot of it is really unknown why we get arthritis in general. But there are a couple of takeaway points for arthritis in the lumbar spine, which I see as an observation, and there are some studies on it. One thing, I'll give you my list of 2 public enemies. Public enemy number 1, smoking. Smoking, everyone knows all the other aspects of it, but smoking actually worsens lumbar facet or accelerates it. Why is that? Well, you smoke, the lumbar disc doesn't get a lot of oxygen anyway, so now when you smoke, you take away more, and it starts to degenerate. See how it starts to flatten? It starts to cause disc bulges. As that happens, look, the joints, they come closer together. And now more pressure is put on the joint. And when a joint or any bone in the body has a lot of pressure on it, it gets bigger. So the joint, it's being pressed on, my hands are the joint, it expands and it gets bigger. Well, now that leads to a whole set of problems, because as it gets bigger, the cartilage doesn't get thicker, it thins, and that gets inflamed. Guess what else can happen as this degeneration process happens? As this pushes down more and the disc degenerates further, this opening where the nerve is, the big nerve, that gets tighter. That's a separate condition. We'll talk about that on our next presentation, but that is called lumbar spinal stenosis. So all of these things. So public enemy number 1 for me is smoking. I tell people, if you were a smoker, thank you for stopping. If you are a smoker, please stop, okay? Because you're just making my job a lot harder, and you're going to make it worse for yourself. Public enemy number 2. We are constantly fighting to maintain our ideal body weight. I know that's true with me. It's true with most of my patients. But that is a fight that we cannot stop. We try to get into our ideal body weight for a very simple reason. The more weight that we carry, the more weight that our spine carries, especially when we're sitting. It puts tremendous weight on the spine. And that, again, can cause increased degeneration and the whole set of problems that we just talked about. Luckily, our patient here has neither of those problems, so she is not our public enemy, which is great. Okay, so I'm going to have you turn just for a second. Now, another thing that's classic in facet disease is pressure, when you put pressure on the joint, that's where it hurts. So where we would put pressure is here. This is where the belt line sits. This is where the L4-5 is, and as we put pressure, yep, there it is. It's right there. We can feel the pain.
Yep.
And if you notice, I just kind of gently do a bend back, so I'm exacerbating. We call this a Gainsland maneuver. And so this side, I'm going to push, and that's okay. Now here's a tricky thing. When she bends this way, if the pain is on the opposite side, it's usually muscular. So pain on the same side, when you bend that side, often it's facet. Of course, there's other criteria. We'll look at that. We have to rule out the herniated disc. Now you sit up here. Now remember, the herniated disc can sometimes present also with the radiating pain, but if it's pressing on the nerve, very simple test that we do. We call it a straight leg raising. This is a seated straight leg raising test. As I lift up the leg, there, it's actually okay. They may feel tightness, but they don't feel whomp, an electrical zinging down the leg, which would be not good. And so again, we always check both sides, and we would do a combination of reflexes and everything else like that. Perfect. So what we're going to do for you is we're going to do a medial branch block, and I'm going to put the medication along the medial branches, and you're going to do that same test. Don't go home and do it. You're going to do it. You're going to do it, and I'm going to talk to you about it the same day after you get dressed, and you're going to tell me how much improvement you get. If it helps, great. Go home. We'll see you in a week, and we check you again. If it comes back, no problem. We do it again. Go home. We check you. 3 is a charm. If both times help, we're going to do the radio frequency ablation.
Very good.